With this, we move on to the next session and we are going to observe a debate. So the debate is on Empagliflozin and Dapagliflozin. So on Empagliflozin, to speak on, we have Dr. Anirban Sinha. He is an experienced endocrinologist, Associate Professor of Endocrinology at Medical College, Kolkata. He is a visiting endocrinologist at Manipal Hospitals, and he is in the editorial board member of several organizations and received several awards. There are a lot of publications to his credit. And on Dapagliflozin, to speak on the topic, we have speaker Dr. Arindam Ray. He is an enthusiastic endocrinologist and assistant professor, Department of General Medicine at Sagar Datta Hospital. He is a visiting consultant endocrinologist at Zenith Super Speciality Hospital, and he too has many publications to his credit and authored several book chapters. I welcome both the speakers. And to moderate this particular session, a debate, I would like to invite Dr. Rahul Bhattacharya. He is a geriatric physician, Director Geriatric Services of Horizon Lifeline Multispeciality Hospital, visiting consultant Bhagirathi Neotia Women and Child Care Center, General Secretary of West Bengal Branch of Geriatric Society of India. I welcome moderator Dr. Rahul Bhattacharya on stage, and I also welcome the speakers.
So before we start, those of you which are still present in this room, by show of your hands, how many
hands are left? That is more important. How many hands are left with?
How many of you use only EMPA and no DAPA? There is none. And how many of you use only DAPA and no EMPA? Never? So, one hand, okay.
Okay.
Oh, two hands. So you are one step ahead. Okay, so let's start. Lodai, lodai, lodai chai. It's time for a fight between EMPA and DAPA. Fight between two molecules, fight between two endos. Let's enjoy.
Yeah. Thank you. First, thanks the organizers for inviting me. I've been here for many years, and I really enjoy the show and academics here. With this, I start my today's debate with my friend and very beloved Arindam. And we all know that we are going to talk about two molecules of the same class. Like the two students of the same class we see. We are theoretically take that all the students of class 6 are of same intelligence, are of same capabilities. But do you really think so? Do you really think that they are really all the same? So the class does not blanketly give the power to the population or the things or the community or whatever it is that they are of homogeneous nature. So they need to be tested of individual capabilities, like you test for the football playing capacity, you test for the maths capacity, you check individually to find out which one is better compared to his friends, compared to his or her competitors, and then we can say that among the class, this one is the best and this one is not so best maybe. So with this statement in the community, I start with the talk on class, two molecules of the same class, EMPA and DAPA. Though honestly we do use both the drugs with the clinical and evidence-based medicine. I'm going to talk in favor of the Empagliflozin, why it should be considered more, because they have more evidence based on it. So before going that, comparison of the trials should be interpreted because they define that particular population or the methodology, so should be kept in mind when we discuss that. Each study do not directly compare the other SGLT inhibitors, though the meta-analysis does so, but individually it is very difficult. Come to the CVOT, the people have been talking for last almost 5 to 10 years at present. Recognize the new international guidelines, though it is again being faded out now, so not talking about, but living by that. So this follows the discovery of CVOT of some anti-diabetic agents have a cardioprotective effects which are at risk. So starting from the SGLT inhibitors, starting from the GLP-1 agonist, so all things have been favored by most of the guidelines because of these cardioprotective actions. And the first CVOT to show the cardioprotection was EMPA-REG, and EMPA-REG did show 10 mg or 25 mg empagliflozin versus placebo, the primary composite was death from cardiovascular events, non-fatal cardiovascular events. How is the time? 16. Okay, fine. And all the patient had established cardiovascular disease, and total 7,000 patients. Observation was 3 years. So this is the graph we all know. This is a very old trial. And same is DAPA. They have looked for declared TIMI. The primary safety outcome again for the MACE events, cardiovascular death, myocardial infarction like ischemic strokes. And primary efficacy outcome was MACE and the composite cardiovascular death or hospitalization for heart failure. And I personally believe both the molecules as the class, they prevent the cardiovascular events not by the vessels but by the pumping system. That is, the heart failure is the key effect which corrected by both the SGLT2s, and that gives the edge over to getting the MACE events to be corrected. And this is the data we have seen that improvements. Is this the marker here? It's not coming there. Okay, fine. Leave it. Let's see the pointer if it works. So is it visible? Okay. See, we can see the difference with the placebo and difference with the renal composite, cardiovascular, MACE events, and the death from any cause. So we do get an advantage, but when we compare this, the dapagliflozin did not result in the lower rates of MACE than the placebo, 8.8 versus 9.4% in the two groups. And among the patient with established atherosclerotic cardiovascular disease, that is the most important patient when we treat the patient with the diabetes with cardiovascular events, the rate of MACE was 13% in the DAPA and 15% in the placebo group. Hazard ratio is only 0.9, that is 10% improvement we can see. Among the patients of multiple risk factors, in real life scenario, we do get these patients more. The rate was 5.3% and 5.2%. So we see almost there is no differences, and the hazard ratio as expected is 1. Mean eGFR was 85, that is pretty high, so it is not been tested in the lower part. 45% of the patient at the eGFR between 60 to 90, which is mostly considered as acceptable normal, if not normal, and 7% of the patient only had eGFR less than 60. But in the real life scenario again, when you see the patients of diabetes, almost 30% of the patient do come with the GFR less than 60. When you calculate it, even if your creatinine level looks normal like 1.2 or 1.3, but if you test it, it can become 52, 56, something like that, if not lower. So I'm not going to canvas, but this is the difference we can see. This is the EMPA-REG and declared TIMI. Major event reduction was 14%, CV events. There is no statistically significant risk reduction in the major CV event. CV death was not statistically significant in the declared TIMI, and so is the all-cause mortality. But if the hospitalization for heart failure, where all the SGLT2 is supposed to work, there also both the thing did reduce events, but EMPA-REG had a 35% risk reduction versus 22% risk reduction with the declared TIMI, and chronic kidney outcomes 46% by 45%, almost similar. But most of the parameters we do see the dapagliflozin loses as for the trial data is available. And coming to the CV risk reduction with SGLT2 inhibitors, and this is again different trials together, that is EMPA-REG, CANVAS, declared TIMI, Credence, VARTIS included. So we can see that decreased CV death in the ASCVD patient were driven by the EMPA-REG when we combine the drugs together here. So combination is improved mostly because of the EMPA-REG compared to the others. Even the declared TIMI does not go. A forest plot did not cross the midline. Similarly, here also that statistical significance is not achieved otherwise. And all-cause mortality again, decreased risk of ACM in ASCVD patient, again driven by the EMPA-REG outcome compared to the CANVAS, declared TIMI, Credence and others. So we can see that EMPA-REG reduction actually improves the combined composite outcomes in this population as well. Now guidelines talk about this as we have discussed. The ASCVD, how much time is left? 12, okay, fine. So we start with the GLP-1 agonist and SGLT2 inhibitor. In my opinion, again, if the patient can afford it, GLP-1 agonist is preferred. And in this, the heart failure trials, again, as I said, these are the most important trials for all the drugs of the SGLT2 categories. That EMPA-REG reduced 3,000 patients with a class 2, 3 and 4 heart failure with the ejection fraction 40 or less actually received the EMPA 10 mg once daily versus placebo, and primary outcome was cardiovascular death and hospitalization to worsening heart failure. Now see the primary outcomes. Empagliflozin significantly improved it. Compared to the DAPA heart failure, we can see again, I'm going to the details of the comparison, then we understand. This is in both the trials, benefit of SGLT2 inhibitor was documented in the primary outcome as expected, because some of the drugs are definitely a class effect, but risk reduction of cardiovascular death was 8% lower with empagliflozin. Hazard ratio was 0.92 and 18% lower with the DAPA in heart failure. But of note, that is the glitch, the large scale trials involving the patient of type 2 diabetes, reduction of cardiovascular death among the patient with similar cardiovascular histories were 41% with the empagliflozin versus only 8% of the dapagliflozin. So you understand, we taken the patients in a distorted way so that get a better outcome. In reality, it may not be the so if you're in clinical practice in real life scenarios. This is the EMPA-REG trial, which patients with markedly reduced ejection fraction, which is compared with the patients of DAPA heart failure trials. So we can see that definitely incidence of the primary outcome was 40% higher in the EMPA-REG that is much better than the DAPA heart failure trials in this population. So when we get the similar kind of heart failure ejection fraction data, this is much better compared to the DAPA. Sorry. Coming to the number needed to treat, empagliflozin it is 19 and number needed to treat for dapagliflozin it is 21. Numerically, again, age over the dapagliflozin in real life, in the trial setting at least. The lesser note factor of the DAPA heart failure trial, there is specific subgroup. Almost one comparison suggested possible heterogeneity with less treatment benefit with the NOAH functional class 3-4 rather than the class 2. So we understand in the patients who are actually more important, like class 3-4, they have a less treatment benefit in the DAPA heart failure trial in the minor clause. It has been documented. So in real life, when the patient actually having the serious heart failure, they may not get the less treatment, may get the actually the less treatment benefit in the class 3 and 4. Coming to the EMPA-REG, the preserved ejection fraction failures, 5,900 patients of 2 to 4 heart failures, given 40% received more than ejection fraction of more than 40%, as explained by the preserved fraction, is received the EMPA-10 versus placebo. Primary outcome again the cardiovascular death and hospitalization to heart failure. This is the difference with the empagliflozin did show consistent efficacy with intermediate and the preserved ejection fractions patients. And this EMPA-REG preserve study shows patients of 41 to 49 versus more than 50, both the groups has a significant relative risk reduction, both in the 41 to 49 reduction is 29% and heart ejection fraction more than 50% relative reduction is around 17%. So both EMPA-REG reduced and the EMPA-REG preserved. EMPA-REG reduced statistical significance was started with 12 days after randomization, so early, and EMPA-REG preserved, it did show at as early as 18 days after randomization. So I'm not going in every details of it because of lack of time. Coming to the kidney trials, another very important factor for diabetic patients because many of the patients are actually renal impaired. So this is the EMPA-Kidney phase 3 randomized double-blind placebo-controlled trial. They looked for CV death or kidney disease progression as defined. This is very important to redefine the situation, like sustained reduction of more than 40% GFR, sustained GFR less than 10%, decline in GFR by less than 10 ml per minute. This is the kidney function loss defined, and the end-stage disease are defined as initiation of chronic dialysis or kidney transplant or renal death. So these factors are important to remember because these are the hard endpoints. Largest trial of the SGLT2 in the CKD patients till now. Stage 4 CKD was significant. These are the inclusion criteria, GFR 45 to 90 or with the ACR more than 200 or GFR more than 20 to 45. This is the way it is included. And baseline demographics of the patients, EMPA-Kidney versus DAPA-CKD is almost similar. We can see here with the, actually we can see with the GFR less than 30 was much more with the EMPA-Kidney compared to the DAPA-CKD trials. And this is the EMPA-Kidney trial, hazard ratio was 0.72. There is a rate reduction is almost 28%. And empagliflozin consistently improves the kidney disease progression and CV days across the various patient subgroups. For again, this trial was not only the diabetes, so even the presence and absence of diabetes, it improves, though the presence of diabetes, it improves more. Cardiovascular disease, even in the presence and absence, it improves. So is the renal disease, diabetic kidney disease, hypertensive, glomerular disease, and unknown factors. All these things clubbed together, all the subgroups did show significant age over, and this ends up in KDIGO guidelines that GFR, even if more than 20, it should be continued even in the patient already on SGLT inhibitor can be continued even on dialysis. So coming to the impact MI, I'm not going in detail. So again, the MI is a very important cofactor for diabetic patients because there's a diabetes is cardiac event equivalent, we all know since our student days. Hospitalization of acute myocardial infarction were at risk of heart failure which received Empagliflozin as a dose of 10 milligram daily within 14 days of admission, and primary endpoint was hospitalization for heart failure or death from any cause. And actual number of heart failure events were low, may have been, there are several other factors, and DAPA-MI, there is no impact of composite cardiovascular deaths have been documented. So I see that even in the cardiovascular events, it does age over compared to the DAPA. I end my talk here, finishing a bit early to save the times. Thank you very much, and it is up to you to decide what you need.
So now it's time for the next speaker, Dr. Arindam Ray, to defend Dapagliflozin.
Thank you, and first of all, good afternoon, and thanks the organizing team for giving me the opportunity. So to start the second part of this debate, I just want to clear one thing that my senior Anirban also already pointed out, that definitely the class of students in the same class varies. Some students are very much brilliant, okay? They are educationally very high, but whether all this I have given them. So whether all these brilliant students are actually successful in their life? Probably not. এরকম অনেক এক্সাম্পল আছে আমাদের ব্যাচে খুব ভালো ভালো স্টুডেন্ট ছিল বাট দে আর অ্যাকচুয়ালি নট সাকসেসফুল ওকে সো দ্য সাকসেসফুলনেস ইন লাইফ অ্যাকচুয়ালি by defined a lot of factors, you know. So practically it is a very important thing. So whether the molecules we are using, the studies, the data that is already shown, I will not go in details of that, but those are not many times practical. So I will just keep on highlighting few aspects of these studies. Those will show you why I am favoring Dapagliflozin instead of Empagliflozin in our practice. So to just brief the whole thing, I think it's very important. Yeah. Thank you. I think this is a very important slide, that how the progression of a diabetic patient happens, you know. So we are dealing, you know, a disease that actually starts maybe 10, 15 years back when it is diagnosed. So it starts from maybe the genetic factor, the smoking, overweight, hypertension, dyslipidemia, and the genetic disease that comes with the prediabetes, then comes the diabetes, and ultimately leads to the comorbidities, that is the CKD and heart failure. So definitely we are getting those patients very early in the phase, not in the late phase like the patient with atherosclerotic cardiovascular disease with the established disease. Now the Empagliflozin, these studies, they have actually carried out with the established heart disease, where the Dapagliflozin, they have shown the CVOT trials with much more earlier patients, those patients who are actually comes to in our clinical practice, that is the first stage patients, that is with the multiple risk factors, where mostly the patients come to our diabetes clinic maybe for the first time. They don't have advanced atherosclerotic disease, they have the primary disease, like suppose a hypertension or a left ventricular hypertrophy or a diastolic dysfunction. But the patients, these are the actual real category of patients, and Dapagliflozin in the study shows it actually works in the pumps, pipes, filters, and they actually reduce to some extent the mess, the cardiovascular disease, heart failure, and the renal benefits definitely to the extreme extent. So this is the window of opportunity, and this is in nutshell all the CVOTs that says the declared TME dealing with the Dapagliflozin actually carries the patients who have a very early stage disease. That is the majority of the patients that actually comes in our clinical practice day-to-day life with diabetes. So this is in nutshell the different inclusion criteria of this trial, and I have shown that declared TME actually deals with the majority of such patients. Now coming to the results, just in one slide. This shows everything. You can see the Dapagliflozin in DAPA heart failure, in DAPA pool data, DAPA CKD, that shows the relative risk reduction, whereas in majority of the studies, empagliflozin, the all-cause mortality like EMPA-reduced, EMPA-preserved, EMPA-pooled, EMPA-kidney, there is not significant reduction. So compared to all this all-cause mortality, definitely here dapagliflozin is the winner against empagliflozin. Coming to DAPA-CKD and EMPA-CKD, again we can see how many the green ticks are there. Definitely the 39% relative risk reduction with the DAPA-CKD study, whereas the all-cause death, composite CV death and all-cause hospitalization all are improved with the DAPA-CKD, whereas there is 2 crosses, the red crosses with this all-cause death and composite CV death in EMPA-kidney. Again, the dapagliflozin is the winner over the empagliflozin. Again, a very important one, if you just think about the second point, the new onset diabetes, whereas in dapagliflozin study, they have shown 32% reduction in the new onset diabetes patients because they have included both the diabetic individuals and the non-diabetic individuals. And the conversion of the rate of the non-diabetic to diabetic is very important nowadays because we want to prevent diabetes, because what we are expecting in next 20 years, India will be the capital of diabetes. So conversion of prediabetes to diabetes should be stopped. And when we are dealing with the metabolic diseases like heart failure, hypertension, dyslipidemia, the chance of conversion is very high. So we are using a molecule in heart failure in CKD patient like dapagliflozin that prevents the conversion of diabetes from prediabetes, definitely is a big winner here. So this is the study by our Shumit Ghoshal and Binayak Sinha sir, which actually shows when we are comparing the different drugs used in this CKD, like starting the SGLT2 inhibitors, GLP-1 and the non-steroidal MRA. Here the SGLT2 groups of agents ranks the highest than the other groups in preventing the progression of the renal composite events in patients with type 2 diabetes. Again, among this SGLT2 class, dapagliflozin ranked the highest among the individual molecules. So this is the result that I can show that dapagliflozin is definitely the winner over empagliflozin, even in the prevention of chronic kidney disease. Coming to the deliver and EMPA-preserved, what is the difference? Definitely the empagliflozin in EMPA-preserved study that shows attenuation of benefit in the heart failure patients with ejection fraction of more than 60%. Whereas in dapagliflozin, in the study that shows the patients with all the ranks with the this ejection fraction, whether it's 40 to 49%, 50 to 59 or more than 60%, we can see the hazard ratio is statistically significant and p-value for interaction that is not significant. Whether the patients within 30 days of hospitalization or whether it's the improved heart failure with ejection fraction, so all the results are actually in favor of the dapagliflozin. So in all spectrum of the patients, dapagliflozin is the first disease modifying therapy across all the spectrum of this heart failure. Coming to heart failure with improved ejection fraction, which is a subcategory of reduced ejection fraction, who actually improved with more than 40%. So definitely the current standard of care with this improved ejection fraction to continue the current guidelines based management. And here dapagliflozin was consistent with the patients with or without prior LVF of less than 40% with this DELIVER study. So there is no benefit of the CV death with empagliflozin even with the pooled analysis. And here we can see the dapagliflozin, the mortality benefits was definitely there, and 14% relative risk reduction in the CV death, the DAPA heart failure and DELIVER study pooled analysis data. So this is the data that actually compare the dapagliflozin versus empagliflozin face to face. And this is a real world type 2 diabetic patients, a multi-institutional cohort study. And definitely the outcome, the composite event of cardiovascular mortality, myocardial infarction, ischemic stroke, heart failure in the diagnosis of hospitalization and outpatient data. And the result shows definitely here dapagliflozin is a winner over empagliflozin in heart failure reduction. At the same time, the similar data for the composite cardiovascular outcome, cardiovascular mortality, myocardial infarction and ischemic stroke. So dapagliflozin was associated with a lower risk of heart failure than the empagliflozin in this study. So definitely they have concluded that dapagliflozin used a significantly lower risk of heart failure compared to empagliflozin. Coming to our own meta-analysis by Pradeep Mukherjee sir, Demallo Sharnal sir, Purushottam Chatterjee sir, Pandit sir and Sujay Ghosh sir. The different SGLT2 class can they prevent the death, and what was the result? Definitely we can say that dapagliflozin may reduce the all-cause mortality but not the CV mortality, where empagliflozin and sotagliflozin may not reduce the either of that. Now coming to practice in India. So definitely cost of therapy is a very important issue, and here the US data that shows the cost effectiveness of dapagliflozin versus empagliflozin, where they have implicated that dapagliflozin may offer greater lifetime economic value when compared to empagliflozin. So if this is a result from Western data, what will be our data? We all know that dapagliflozin is widely available nowadays within 9 to 15 rupees, where empagliflozin is around 50 to 70 rupees. So if you totally think of the cost of therapy, here again dapagliflozin is the winner over empagliflozin. This is the last part I want to discuss. The FDA approves the dapagliflozin for children with type 2 diabetes. So any children patient of more than 10 years of age, dapagliflozin is the SGLT2 class that we can use for type 2 diabetic individuals, not the empagliflozin. So here, definitely, this is the last slide, the dapagliflozin and empagliflozin. I don't want to discuss anything more here. I have already discussed. The choice is yours, and thank you. We want justice.
Wonderful. So have you changed your mind, any one of you? You have 6 more months before empagliflozin goes off patent. So there has been a definite surge in DAPA prescriptions after it has gone off patent. But things will get more complicated after 6 months, I'm sure. So since none of the speakers are interested in any rebuttal, let me conclude our session here. And since we are already running behind the schedule, so may we invite the announcer, please?
Absolutely. Thank you, speakers. We had a really enriching and engaging session, I would say. I would request you to kindly stay back and request Dr. Rahul Bhattacharya to felicitate the speakers. Thank you, Dr. Arindam Ray. Thank you, Dr. Anirban Sinha. Thank you, Chairperson. Thank you, Dr. Rahul Bhattacharya.